So I'm going to be talking a little bit more about providing assisted dying, and you heard from my two provider colleagues what the experience has been like, and I can tell you more, not only from my own experience, where am I going here? But because we also have a robust research program in Canada, and we have a research group, part of CAMAP, that meet by webinar, and we have research forums, which we'll have the day before the CAMAP meeting in Vancouver, and we'll be presenting Canadian research to each other and supporting each other. So at this point, there are 2 papers published on the experience of Canadian providers and 2 in process. And so, as I said, I can give you information that's not just personal from the 3 of us, but from our colleagues. So the one overwhelming thing that comes out of each of the research projects is providing medical assistance in dying is rewarding. And you can hear what other people have said. Being able to give someone this gift, people are incredibly thankful. The families, the patients, it's a bit overwhelming. And another said, the work is so wonderful to offer something that these patients really, really want and deserve and have the right to. And they are so grateful. Oh my heavens, they are so grateful. And then in the interviews with the various providers, they were asked about challenges, about problems. So first of all, there were the structural challenges, and you've heard some of them already. Dealing with hospital and care home staff, transferring patients, dealing with just the nitty-gritty stuff of getting drugs from the pharmacies. Pharmacists, of course, can deny you, and in my case, I have a pharmacy close by that has exactly 3 pharmacists, of which 2 will provide and 1 won't. So I have to always know the schedule of my pharmacists when I'm planning my deaths. And the total time involved in all our documentation can sometimes be overwhelming. And then they talk about the emotional challenges in this research. Over and over again, these doctors said the hardest thing they ever did in MAID care was to refuse someone based on the fact that they were not eligible for under our law. Saying no to patients never gets easier. And, you know, all of us want to work within the law because we'd like to keep working. Another emotional challenge is disagreements with colleagues. I mean, these are the people we work with, right? And so it's really tough when they'll disagree with you about whether somebody is eligible, and you know, we still need to work with this colleague afterwards. And so it can be, you know, Tanya says take no prisoners, but these can be your friends that disagree with you, and then you have to cope with it. And of course, some are great celebrations, but sometimes the grief that we see in the room is amazing and difficult to deal with. And then there's the fact that you saw that there are only a few of us doing a lot of the work. The Island Health Authority, what did you say, 26, 24 providers? My health authority, which is similar size, I think a little bit bigger, has exactly 7, of which 2 are physicians, me and 1 other, and the other 5 are nurse practitioners. We're really busy. And so the amount of hours that goes into this, I mean, for example, the 11 days before I left to come to South Africa, I had 10 deaths. Each one takes hours and hours, and it was way too much. It was good. It was a good 2 weeks, but I mean, I was working from morning till night, every day. So what have I done in this time? I've completed 154. You can see the diagnoses. I've assessed 300 And of those, then 40 I refused, and you can see that 7 were for capacity. Generally, these are people who've been referred too late. Somebody has asked for MAID, I get there, and there's delirium, terminal delirium going on, and I can't provide. 22 were because of having an illness. For example, a 51-year-old with very severe arthritis, completely crippled, unable to care for himself in a care home, only 51 and only with arthritis. And I had to say no. And then the ones that are primarily psychiatric, and the hardest ones of those are not someone like Adam Mayer Clayton, who went public and you heard about from Shanaz, but the somatoform or somatic symptom disorder people, like Erica was talking about, people for whom all of their suffering is horrendous and physical, completely and totally physical, and yet there's no physical cause, so they're given a psychiatric diagnosis. So, I was a doctor for 40 years before we had assisted death. So I knew death. I mean, I was a family doctor. I did end-of-life care, along with everything else. And so I'd had this conversation with my patients many times, we'll keep you as comfortable as we can. What people don't fear as much as the doctor does is that agitation, that terminal delirium that's just so dreadful. They want to be in a good place. Where would you like to die, and with whom? Not in an emergency department with somebody vomiting and screaming beside you. But the new thing, the brand new thing, the new conversation that we're having with our patients that I've never had all those 40 years is, when would you like to die? Where would you like to die? Who are you going to invite to the death? And which method? So occasionally we can use real names because they have gone public, their families have gone public. The very first patient that I assisted, which was the first person out of Quebec that had an assisted death, was Hannah Schaefer, who was a 66-year-old retired psychologist. She had motor neuron disease, unable to speak, feeding tube, required 24-hour care. So there was a few problems with the very first case. First of all, she lived in Alberta and I lived in BC, and there were no providers in Alberta, and she had to fly on the last day of her life an hour to Vancouver in order to have her death. The College of Pharmacists, who licenses pharmacists, wouldn't support them, so I had no pharmacists. So I had to get drugs without the pharmacist knowing that I was using them for assisted death, which was not great. I couldn't get a nurse to help me. This poor woman was stuck with me as the person who put the intravenous in. And believe me, that is not the best care that one can get. I got it in one try, but she was lucky. And then where were we going to do it? Not the airport, not the hotel by the airport. Let me think. She can't go to a hospital or anything. She's from the wrong province. I asked my husband, can I bring her home? He said, no, I don't think so. So I brought her to my office, which was an abortion clinic, and it was perfect. Abortion clinics have nice, calm sort of places to relax and have family around, and so we've done many in the abortion clinic since. I'm going to tell you a few more stories. Rita, which is not her name, 86-year-old with end-stage lung disease, living alone at home, and stuck on, oxygen, able to walk only a few steps and then rest for half an hour, and then, she could make it to the toilet now with great difficulty and nothing more than that. She said, my life has shrunk, I'm ready to go, I had a wonderful life. She was able to convince me very quickly that she was not depressed and that she was very clear thinker, and So she chose not to have her family with her. She chose to have them come and say goodbye earlier in the day. 3 friends came by with champagne and opera music and read poetry as she fell asleep. Now here's a Canadian issue. You heard a little bit about our geography. So Rod was living on a remote island, alone in a cabin, as he was a loner. The nearest health facility of any kind was on a different island, and he had metastatic prostate cancer, using a catheter, increasing weakness, and because he was unable to take care of himself in his own home, he felt that that was intolerable at this point because he did not want to move. The only care home available to him was inside the hospital of this other island. It wasn't something that he was willing to do. There's a picture. The bottom arrow is where I live, and the top arrow is where he lived, which is just below Alaska, the panhandle of Alaska. And that was the community as we flew in. The blue building there is the hospital. So there were lots of problems. He was the kind of guy who was angry at everybody because, that's the kind of guy he was. And he wanted his body buried at sea, but that's against the law. Or near his home, which was Indigenous land, and he wasn't Indigenous and wasn't allowed to, didn't have permission. He wanted to just get medication and take it home, but that's not allowed in our province, and I wasn't willing to go. Nobody was willing to go to his island. For one thing, I can't get around in places like that. The local medical staff felt that he must be crazy because he wouldn't refuse their kind of care, which was to come to the hospital for continuous care. After much negotiation, we used telemedicine, that is video, to assess him. I for the hospital with the MAID coordinator. We did it in the hospital, so he had to be transported from the other island to the hospital, which he was willing to do. He wasn't willing to live there, but he was willing to go there. And his neighbors came with him, and he had negotiated with the Indigenous group that he was allowed to be buried in Indigenous land. And it all worked. It all worked. He was in a good mood and pleased with the arrangements for the day. The staff, it was a huge problem. It was their first, and over and over again, we're with people for whom it's their first, and they have to deal with, it being their first. Okay, Peter, 48-year-old with end-stage multiple sclerosis, in a care home for 18 months, no longer able to sit, had some infections. So he could have lived for a while longer, but only if he was willing to have these infections treated by being moved to an acute hospital in the intensive care unit, because once you get multiple sclerosis to that level, you can no longer cough well enough to bring up secretions to heal up from a pneumonia. You can get bed sores, and they can't heal in the care home. They would have to be specially treated, etc. So he decided he was done. Problems. His wife was really angry at me, said it was too easy, I hadn't used proper process, and made formal complaints against me. So, like Erica talked about, I've had a number of formal complaints, and they happen in these kinds of situations, sometimes with the family member. The actual death was perfect. The care home moved his roommates out of the room. He was with 2 demented elders, this 48-year-old man, I know. Brought his dad was there and brought his dog there, and his dog was curled up next to on his legs. And he was so happy to see me. He'd been waiting and waiting and waiting till I arrived. And after it was over, his father said, I was there at the beginning, and I was there at the end. And then we had this deal with the complaint, which went to the College of Physicians and Surgeons, and they took months, and lots of people were involved, and lawyers and all that stuff. And it's fine, because what the college cares about is that I did all the right things, and I did all the right things, and so. But it's just another hours and hours and hours of work when these things happen. So this is the paperwork that we are required at this point to complete, 18 pages. And as of November 1st, we don't know how many pages it'll be. It's going to be all different. But overall, I can tell you that this is the best work I've ever done. I am so grateful and so honored to be able to do this work. And it's not just the three of us who feel like this. The research that we've seen shows that so many of us are feeling like that. So those of you who are from countries where you're expecting to get legalization soon, there are people like Stephanie and Tanya and me, a whole lot of them actually, who love doing this work because, doctors love grateful patients, and we just get so much of it. Thank you.